Hello, everyone. Thank you for coming to our webinar on exercise after pregnancy and how to get started safely. My name is Katie Ouillette-Harrington. I am a doctor of physical therapy and a pelvic health specialist, and also a sexuality counselor and educator. So before we get started, there is a Q&A box in the Zoom app or whatever you're on. So if you have any questions, you can post there and it will be anonymous, and then we will get that and answer that at the end. So the objectives of this presentation, we're going to learn the basics of your core and pelvic floor and how pregnancy affects its function, learn about common dysfunctions during and following pregnancy. We'll educate you on the safe return to exercise following pregnancy, and then learn how pelvic floor physical therapy can help. And a little bit about myself. I got my associates as a health fitness specialist and became a certified personal trainer through Delta and the National Strength and Conditioning Association. I finished out my college career at Central Michigan for my bachelor's and my doctorate. And then ever since then, I've been doing pelvic floor education classes. We don't really get much of that in college. So been doing that for about 5-ish years now. And then I also went through the University of Michigan School of Social Work to become a sexuality counselor and educator. And personal life, I live in Midland with my husband, my two stepkids, 3 dogs, and then I have 2 babies on the way that should be here for the next 6 or 7 weeks. We're avid in camping and hiking and staying active. All right, so we'll jump right into the anatomy of pelvic floor anatomy of a female body. So on this picture on the left side, we can see your bladder, uterus, vaginal canal, and then your rectum. They kind of sit one in front of the other. This pink orange color that you see on the bottom that's connecting from your pubic bone to your tailbone is your pelvic floor. And then this image would be from down looking up towards your head at the pelvic floor. So this front side would be your pubic bone. We have your tailbone and your buttocks here in the back. Then we have your urethral opening, vaginal opening, rectal opening. We have your extension of some of your hip bones right here. And then all of this red is your pelvic floor. So we have 3 different layers of your pelvic floor pictured here. And then we have your glute muscles in the back. So functions of your pelvic floor, we talk about the 5 S's. First one is support. So the muscles act as a basket to support our pelvic organs, our bladder, rectum, and uterus. And that helps to support against gravity and abdominal pressure. The sphincter control, so that is wrapping around the opening of the bladder or the urethra and the rectum to prevent leakage of either stool or urine. But those muscles also have to be able to relax for fully eliminating the bladder and the bowels. Stabilization, our muscles attached to the hips and the pelvis, so they play an important role in stabilizing all of our joints around there. For sexual function, the pelvic floor muscles help achieve erection of both the penis and the clitoris. The muscles also have to allow for penetration. So sometimes if they are too tight or overactive, it would be difficult to insert anything into the vagina. Dysfunction can lead to pain with intercourse or difficulty maintaining an erection or achieving an orgasm. And then lastly, we have the sump pump. So with that movement that we see in this picture, how the pelvic floor works with the diaphragm, that motion helps pump blood and lymphatics back towards your heart. So we see how it does that pistoning motion with use of the diaphragm. So what makes up your core? So your pelvic floor is the bottom of your core. If you think about your whole core from front to back that's in this picture, think of it like a pop can. The bottom part is your pelvic floor, which we've seen, which would be down here. The front is this transversus abdominis. It's like a corset muscle. So it wraps around from the bottom part of your ribs down to your pubic bone. It comes in along the hip, and then it inserts into the connective tissue that's in your low back. It is the deepest abdominal muscle, and it works directly to support your pelvic floor. It actually should co-contract with it, so they should contract together. before movement to lengthen and stabilize the spine, pelvis, and pelvic organs. So the front of the pop can is the transversus abdominis. The back of the pop can is what's called this multifidus. It's a muscle that runs along your spine, short and deep, but their main job is to stabilize this whole area. So that's the back of the pop can. Top of the pop can is our diaphragm. So it lowers and flattens when we inhale, and it elevates when we exhale. If we think about this pop can analogy, when all these muscles are working properly, it's like the pop can is closed. If anything were to prevent these muscles from working properly, it's like we open the pop can and the integrity of it changes. So when the pop can's closed, you can't really move it very much. When it's open, that's when the integrity of it changes. It moves a lot, it's not as stable. And what would change these muscles functioning are if you have low back pain, if you've had any type of abdominal surgery, low back surgery, pelvic surgery, if you've been pregnant, or if you have pushed out a baby, or if sometimes too, if you have any breathing issues like asthma. So your core at work, we went through that breathing or that pistoning system and why that's important for maintaining abdominal pressure. So that canister, that can balance is important for controlling the increase in intra-abdominal pressure and decreasing pressure on the pelvic floor. Meaning if you're going to lift something heavy and you're holding your breath, your core needs to kind of brace against that so that not so much pressure comes down to your pelvic floor. If you have dysfunctions in either of those muscles, you're going to increase pressure down to the pelvic floor. That can increase your chance of leaking and prolapse, which we'll talk a little bit more about that later. So that's what's considered your core. Next is our abdominal muscle. So this is just the front of the muscles. We have your transversus abdominis, which is your deepest one we just talked about. Your rectus abdominis is the six-pack muscle, which most people, when they think about your abdomen, that's what you think about. So it's along the front from the bottom of your sternum all the way down onto your pubic bone. And then we have your obliques. Those come in at an oblique angle. We have your internal and external oblique. Body changes during pregnancy. So we can see in this picture here, your uterus is way down here. All of your colon's all up here. We have your rectum, your bladder, and then your stomach. And then when the baby starts to grow inside of your uterus, everything gets smushed. So your colon gets all smushed up there. You'll have pressure down onto your rectum, pressure down onto your bladder. So with these will come posture changes. So you'll start to have an inward curve of the spine. So if you look at the spine in this picture, we have a nice normal curve. Once your baby starts to grow and it pulls on the front here, we see that curve increases a little bit towards the front. That will cause that transversus abdominis muscle, that main core stabilizer, to lengthen. So we're going to lose some stability there. And some of these changes can also persist postpartum as well, if we're not addressing them. With that, we might also start to have forward shoulders. So with losing strength in the core, we kind of can start to slump forward, especially if you are breastfeeding or bottle feeding, because we kind of get into that position, or holding a baby a lot, we kind of just start to flex forward. Or if you're holding the baby on one hip a lot, you might start to notice some pain or discomfort there. And so with that forward head, kind of rounded shoulder position, that increases pressure and load down onto the pelvic floor. So that would increase our chance of having leakage and a prolapse. And our abdomen and our low back muscles are least active in this position. So then we're not only increasing pressure down onto the pelvic floor, we are losing the stabilization of the rest of our canister, and that will increase even more pressure down with the pelvic. All right, more changes during pregnancy. So we talked about the abdominal muscle changes with the transversus abdominis. Towards the end of the third trimester, almost everybody will have what's called a diastasis recti, diastasis, tomato. We shorten it to a DRA. This is where those rectus muscles, those six-pack muscles along the front will separate. And then there's a piece of connective tissue in between that called the linea alba, and that will stretch out. The transversus abdominis muscle we talked about gets lengthened, and that will cause that functional strength loss. This can persist postpartum and what we call mommy belly. I hate that term, but that's how people know it. Some people will have the diastasis or the DRA that will improve on its own after giving birth. Sometimes it does not. What you will notice is if you're like lying on your back and you go to sit up, if your stomach domes or it peaks, that means you probably have a diastasis. That can be addressed with strengthening, and we can talk about that later. Pelvic floor changes. So our muscles, connective tissue, and nerves will become lengthened and strained, causing stretch-induced weakness and poor coordination. Even if you don't have a vaginal delivery, that will still happen because of all the extra pressure and weight coming down from being pregnant. These muscles can also spasm due to trauma post-vaginal delivery or due to core weakness. So we talked about how our pelvic floor and our core are both part of our canister. If one of those sides of the pop can is weak, sometimes other muscles will try to overcompensate. So we'll often see with core weakness, the pelvic floor will start to tighten or spasm to try and compensate for the core weakness to add some stability. So we'll talk about both the C-section and vaginal delivery and how those changes will affect your body. So with a C-section procedure, you can have a vertical or horizontal bikini incision. Vertical or horizontal / bikini incision. So we'll see that at the bottom picture here. This is vertical. Most often we're going to see this horizontal or bikini incision. It heals well and it has less bleeding. So most often your OB will pick that version. And then that's going to cut through the abdominal muscles and the fascia. And then your muscles kind of get spread to get to the uterus. So that will obviously affect how those muscles are functioning. And then incision to the uterus, there's a couple different ways. They either go low, horizontally across, vertical, or right in the middle. And your fetus or fetuses will be taken out. You deliver your placenta, which they will also just take that out. And then you're sewn up layer by layer. There's another image of how you're being cut open and the baby is taken out. The main thing that we see here is a lot of core weakness following a C-section, which understandably, those muscles are getting cut into and moved to get to the uterus. All right, with a vaginal delivery, it's common for the perineum, vulva, and vagina to tear to some extent during childbirth. The perineal area is the area between your vaginal and anal opening. Most first-time birthers who have had a vaginal birth will experience some sort of tear, graze, or an episiotomy. Episiotomy is, I will go over that in the next slide, but it's when they purposely make a cut, usually to prevent major tearing or to get your baby out quicker. It's slightly less common to have these for people who have had a vaginal delivery before. Most often, these tears are minor and will heal quickly, but these injuries and trauma will change how the muscles function and should be rehabbed following, because that's a pretty extensive injury there. So we can see 4 grades of tearing. So grade 1 is small tears, only affects the skin. They usually heal quickly and well without treatment, and you don't need stitches. Grade 2 tear, that affects the muscle of the perineum and the skin, and they usually require stitches. So you'll see here. Then we have grade 3 and 4. These are not as common, but they do happen, and they will be much deeper. So these extend into the muscle that usually extend into the muscle that controls the anal muscles or the rectal muscles, and they usually need quite a significant. All right, so we went over the 4th degree tear. We didn't get the episiotomy, right?
Correct. This is where we left off.
Okay, so with episiotomy, that has a cut into the perineum and the vaginal wall to make more space for your baby to be born. This is most often happens if the baby needs to be born quickly, or if you are having instrument-assisted delivery with a forceps or vacuum, or if you're at risk of a serious perineal tear. This will more so happen with the pending serious risk if your baby is large, and or if the birthing person has a little bit of a smaller pelvis and it's not opening. So keep going. We're going to keep going with the common impairments during and after pregnancy. We talked about the diastasis or the DRA. It's normal during the end of the 3rd trimester. Like I said, some heal on their own, others require more therapy. But we want to mainly avoid exercises that increase doming or separation. So if you're doing an exercise where you notice you're losing tension in those abdominal muscles and that peak or that dome happens, or you're noticing, a good way to check on yourself actually is if you lay down on your back, you put your fingers like this way into your stomach around your belly button, and then you lift your head and shoulders up. If you feel any muscle separation, move my fingers closer. You would feel your 2 muscles on the side of this. If you feel like you can sink your fingers in at least 2 finger widths or more, that means that you have a diastasis. And then we can see in this picture off to the right of the slide about how they can separate different areas. So you can have just around the belly button, you can have it below the belly button, above the belly button, or along the entire rectus abdominis. Pubic symphysis pain is also common. That pubic symphysis is that bone on the front of your hips. That joint can actually separate, not often, but it can separate or become irritated or a little bit more unstable during pregnancy. That can cause pain in the pubic bone, but it can also refer pain to the vulva, vagina, groin, sometimes lower abdomen. This will worsen with doing stairs, getting into and out of the car, or hip movement. So if you're with your legs coming apart, or if you are squeezing them together, that can also cause that pain. This can persist following delivery if you have, especially if you have any sort of pelvic or like SI joint pain before pregnancy, and that's not addressed, that can still persist following delivery. Incontinence is another common one we see. This can be leaking of urine or bowel excrement, so feces. This can happen during pregnancy and or postpartum. We can have urge, stress, or mixed urinary incontinence. So urge incontinence is when you have leakage with a strong urge to go. Stress incontinence is leaking with coughing, sneezing, laughing, lifting, running, or you can have both. This can be due to muscle weakness in the pelvic floor or core, overactivity in the pelvic floor muscles, or both. So if your muscles in the pelvic floor are overactive for long enough, meaning you're like holding a chronic Kegel and you're not letting go, the muscles will eventually become weak because they're not moving. So that's where we see that dysfunction come in. Pain with intercourse is another common thing we see that can happen post-vaginal or C-section delivery. That can happen with scar tissue restrictions if you went through vaginal birth, also with tear or trauma to the muscles. You can have loss of vaginal moisture if you're breastfeeding or pumping, or you're like feeding breast milk because of decreased estrogen that goes through your body, and that will cause dryness. So what we recommend is a gentle water-based lubricant for penetrative intercourse. Usually I would say the less amount of ingredients, the better, especially if you're prone to irritation of your skin. A daily moisturizer is also good. It will take cells like 30 days to regenerate and turn over. So using that daily moisturizer would be important. Some brands are Good Clean Love, Demiva, Intimate Rose, or Replens. Oral supplements are also an option, but definitely check with your provider if you're giving any breast milk, because that can sometimes go through to the milk. Membrazin can also be used as a cream, but there isn't a supplement for that. And sea buckthorn oil that helps to increase the natural lubrication in the vagina. So another common one is low back and hip pain, especially during pregnancy, but this can also persist afterwards. This can be due to the abnormal postures we talked about a few slides ago, or pelvic floor strength and stability, because again, that bottom of the pop can or the canister, if that's has any dysfunction, it's going to change how everything else functions, and it is an important part of stabilization of all the joints. Poor alignment, meaning sometimes if our hip bones are not where your body wants them to be, or muscle imbalance. We can also have pelvic organ prolapse. So laxity in the walls of the vaginal canal from any direction, front, back, or top. Symptoms are normally lower abdominal or vaginal heaviness or pressure, difficulty emptying the bowel or bladder, seeing, or also with that, I might have difficulty starting a urine stream or a bowel movement. You might have to push around that perineal area or in the vagina to start a bowel movement. If you see or feel a bulge in the vaginal opening, any incontinence of any kind, and then sometimes pain with intercourse. So if we look at this picture off to the right, you can see this is anatomy without a prolapse. Here, this is also, these pictures are higher grade. So we grade prolapses on a scale from 1 to 4. 1 is 0 is nothing, 1 is minimal, 4 is the worst. These are, we're showing these to be a higher grade to show you what it looks like. So if you have one, that doesn't necessarily mean it's this bad. So bladder prolapse or a cystocele. That's where the bladder or the front wall of the vaginal canal is coming in. You can have a rectal prolapse or a rectocele. That's when the rectum is coming forwards into the vaginal canal. So that's from the backside. Or your uterus can come down the vaginal. So with therapy, if we're treating a pelvic organ prolapse, we can usually see an improvement of at least 1 grade, an improvement of symptoms. So grade 1 through 3, the first line of treatment should be therapy. Grade 1 through 2 the first line of treatment should be therapy. That's usually can be easily managed with conservative measures. Grade 3 should trial physical therapy. Sometimes if we can't get it to go back to where it was, that's okay. If we're improving symptoms, that's great. Grade 4 will likely require surgery. So usually if we see a grade 4, there's not really much that we can do, but a pessary is also an option, which we'll go over in the next slide. So a pessary is a removable device that provides support after a prolapse. This creates the ability for a patient to forego or extend their time for a surgical intervention due to a pelvic organ prolapse. But can it also help with symptoms, including leakage, heaviness, or bulging, or pelvic pressure? So some people only wear these during activities that will increase those symptoms, like exercise. So I've known patients that just put those on to run or lift. There's many different types. So there's one, it depends on what type of prolapse that you have. So you can kind of see those in these pictures, and your OB or your midwife will be able to decide which one would be best for you, or a urologist. All right, so exercise guidelines. Birth at minimum causes an injury the size of a dinner plate internally. So when your placenta comes out, that's about the size of a dinner plate. That is the injury to the inside of your uterus. You can also have abdominal or vaginal trauma, depending on the delivery type. It's important to be checked out by a therapist to help treat the dysfunction if necessary, and to just do a check to see how everything's functioning. So even if you don't need physical therapy, I think that everyone post-delivery should at least be checked out by a pelvic floor therapist to make sure everything's okay and that you're not causing any further issues if you do have any. I recommend not returning to previous level of exercise until your 6-week checkup. Your tissues need time to heal. Like I said, you went through a major trauma, and we need time for all those tissues to heal. But it is safe to do light stretching, strengthening, and walking. We'll give examples of that later. Be mindful of your symptoms and use these as a guideline. Any pain, pressure, or heaviness, leakage, or abdominal donate. So if you are experiencing any of these during and after exercise, you're probably doing too much. I would take a step back, regress the exercise, and try again later. Later as in like a couple days or a couple weeks. If your symptoms persist, I would seek care. Ask your OB or your midwife or your general practitioner for a physical therapist to assess and treat what's happening. OBs are usually really good about referring to pelvic floor therapy. So key points here, using your breath. So a lot of times we will tend to hold our breath if we're doing something strenuous. And like we talked about how breathing helps manage your intra-abdominal pressure, it's important to make sure you're breathing during exercise. So anytime when you are exerting effort, like you're going to lift something or you're squatting up, anytime that effort is coming, like the harder part of the exercise is when you should breathe out. So you exhale on the effort. You want to avoid, with that next point, avoid excessive downward pressure on the pelvic floor or lifting too heavy. Make sure you're stacking your rib cage on top of your pelvis, maintaining good posture with pelvis in neutral. So our pelvic floor would be in the optimal position for correct firing and support of our organs. And you don't want to do too much too soon or with presence of significant dysfunction, as this could further issues. So prolapse, pain, and leakage. So how do we fix these issues with therapy? It will depend. So if you have weakness, we're going to strengthen the core, pelvic floor, and the hip. We'll work on posture corrections and proper breathing. If you're having a lot of muscle tension, we need to relax those muscles first and then strengthen them if they need to after. But we will also work on core strengthening, again, because that will help the pelvic floor relax. Breath training and stress management. And then if you're having a lot of urinary frequency and urgency, bladder retraining can be really helpful for that. So we understand optimal bladder habits and functioning and decreasing irritants that could be causing you to have to pee a lot. So pelvic floor therapy, we just do a lot of Kegels, right? No, we do not. They are not always the answer. You might need to down train or lengthen the muscles before we up train or strengthen them, kind of coming back to that pelvic floor overactivity. You might not even to do Kegels at all. You might have a strong and great pelvic floor, but the reason that you might be having leakage is because your core is weak or you have that abdominal separation. So if you experience pelvic pain, pain with intercourse or vaginal penetration, urinary frequency and urgency, Kegels might not be appropriate for you to start with. We also, even if you do need to do Kegels, you want to make sure you're not doing too many. So just like you wouldn't do 500 bicep curls a day, you don't need to do 500 Kegels a day. Then we just don't want to do them willy-nilly either. Usually when we're prescribing an exercise, there's a hold time. There's how many reps and sets we want to do. Pelvic floor muscles are still muscles, so we want to treat them like we would any other part of the body. If we do need to Kegel, this is how we're going to do it. A couple different cues that will resonate differently with every person. Pretend there's a ball or a marble low in your pelvis. Tighten around that object and lift it up, like you're trying to lift it up with your vagina. Tighten your muscles if you are holding back gas or trying not to urinate. Pretend to tighten your vagina around a tampon. Draw your sit bones towards each other. That's the bony part of your butt. Draw your pubic bone and tailbone together, so front to back. Penis owners, that would not apply, I don't think, to most people here because this is post-pregnancy and you need a uterus to be pregnant. What you should not feel. So you should not feel abdomen, buttocks, or inner thigh muscles tightening. So I should be able to look at you and not tell you're doing a Kegel. Sometimes people will overactivate with their butt muscles. And then you'll see them kind of like lift up when they do a Kegel. Your pelvis should not be moving. So this will be easier lying on your back, on your side, or on all fours. It will be harder and seated and standing because you're lifting against gravity. And then before you start the next Kegel, you want to make sure the pelvic floor is all the way relaxed. So because we talked about how important breathing is, we'll go over a breathing demo. So if you are sitting, make sure your feet are flat on the floor. Your upper body is upright. Body scan first. Make sure your muscles are relaxed. So relax your jaw, relax your shoulders, relax your belly muscles, butt muscles, and your pelvic floor. When you're relaxing your pelvic floor muscles, just like we said, one of the cues to do a Kegel was to bring your sit bones together. Be able to relax is the way to think about bringing your sit bones apart. We'll place one hand on your chest, one hand on your belly. You're going to take a deep breath into the hand that's on your belly. So think belly first, belly big, chest little, chest last. Take a deep breath in. You should feel your belly come out, and then you should only feel your chest a little bit. We also don't want your shoulders to rise too much. And you want to feel Ideally, movement around your entire rib cage, so 360 degrees, because that's how our diaphragm. These are good to do like 30 reps at a time, as many times as you can think of throughout the day. It also helps regulate anxiety and stress. Transversus abdominis demo. So you can do this either lying down or seated. It'll be easy, or lying on your side. So we don't want to overactivate with the upper abs or the side abs. So sometimes if this muscle is weak, people will try to compensate with the rest of the abdominal muscles, so the rectus and the obliques. We want to think about drawing in the lower abdomen. So your lower belly just above the pubic bone. A cue that works for most people is to think of that there's a wire or a string connecting from the front of your hip bone, so right across the front. Try to tighten this wire. So you should feel, when you do that, you should feel your lower abdomen muscles tighten. If your hands are there, you should feel it move away from your fingers. If your hands are there, you should not feel this muscle bulge out or push out into your hands. You can also say, shh, with drawing the lower belly in, and that should also help. And it would feel, again, like the muscles are moving away from your fingers. Think about narrowing your waist, or you're putting on a tight curve. All right, so we're going to go through a few different exercises of what you can do right away post-delivery that will help your muscles kind of get back on board and remember how to work. So the transversus abdominis demo that we just did, you can get a little bit of a better squeeze if we add in your inner thighs. So you can do this lying down or seated. You put the ball in between your legs, and you would do your belly brace and squeeze the ball at the same time. If you don't have a ball, you could do a rolled up towel or a folded pillow. You should feel that muscle tighten underneath your fingers. Should not feel bulging out. Hold it for 5 to 10 seconds. You can do that 20 times. And this will be in the post presentation email, I believe. Another good one is an open book. So kind of like we talked about with pregnancy and postpartum, we start to get those shoulders rounded. This helps open everything back up and encourage better posture. So you lie on your side, your bottom leg is straight, your top leg is bent, rest it on a pillow or a ball. Arms are going to go straight out in front, and then you're going to open up and follow with your eyes, and then bring your arm back. You should keep your elbows straight. And then once you're coming back to, and make sure your top knee doesn't like come back off the ball. You just want to go far enough to where you're like fully open. You should feel a stretch in your upper back and probably in your chest. You do 20 on each side of these. Oh, I forgot to change this picture. So this picture is not a representation of what this exercise is. So with the supine angel, you're on your back with your knees bent. Arms are in a 90-90 position like this. Exhale and then blow out all of your air through your mouth. And then at the very end of that, you will note how your abdominals contract and force your lower back to depress into the floor, or your low back arch should flatten. So you're going to keep this position and do a couple breaths here. But you don't want to allow your abdominals to relax. You don't want your low back arch to come up off the floor. So you're going to hold that position. And then what you're going to do is you're going to breathe in. As you breathe in, your arms are going to come up like this over your head. You'd exhale and come back down. This would be, I think I said, lying on your back with your knees bent. You're going through this motion, kind of like you're making a snow angel, but your arms aren't straight. Keep your rib cage down. You do this, so 20 times a day for that one. Mini squats are also great to do. I wouldn't go full depth, so that's why we're staying mini. So it'd be like about 1 foot away from a chair or a countertop. Your feet are about hip width apart. Make sure your weight is on your heels, because when you go down, you don't want your knees to go over your toes. So you're almost going to put your butt back like you're going to sit into a chair. Go into about a quarter or a half squat. And then when you come into standing, you're going to lift your head up and kind of open your chest a little bit. That will be great, especially after a C-section, to kind of stretch out that scar at the bottom. Chest and bicep stretch, also good to open up the chest and the upper back. You can do this in standing. Your hands will clasp behind you. You're going to bring your chest forward. You should feel a stretch in your chest, a little bit in your abdomen possibly. If you want to feel more of a stretch, lift your head towards the ceiling, holding that for 60 seconds. And then this last one is, again, opening this upper body up here. So you're going to bring your shoulder blades down and back and kind of pinch them together. And then your arms are going to come out to the sides, like you kind of shaped like a W. And you don't want to make sure you're not raising your shoulders when you do that. We don't want to get those upper trap or trapezius muscles involved. We really want to get those scapular muscles that help with posture. Hold for 5 seconds and do that 10 times safely. So if you were to need pelvic floor physical therapy, what is it like? So we do a whole body evaluation. We're looking at your deficits that are likely contributing to your current complaints. So this could be muscle weakness, this could be trigger points, or if you have painful areas. Do we need to look at how your range of motion, how your muscles, are they able to lengthen? How is your stability? Do you have any pain? Do we need to do any bladder retraining? So common things we'll see, we talked about incontinence, urgency. We can treat constipation, any pelvic pain, pelvic organ prolapse, pre and postpartum pain, which is what main discussion was here. Any abdominal pain, tailbone pain. That's also something that can happen post-delivery. Diastasis recti, or that DRA, pudendal neuralgia is another form of pelvic pain. As a side note, we also work with pediatrics. And we're looking at this as an individualized treatment approach. So if I eval'd 5 people, they each have leakage, their treatment's probably not going to be exactly the same because their deficits might be different. So we just need to look at what's causing it and we'll treat that. And we assess the entire system. So we're not just looking at the pelvic floor like we've talked about. We're going to look at your core and your hips and your breathing and your posture. So if you are having any heaviness or bulging in the pelvic area, leaking urine or inability to control bowel movements, if you're seeing that presence of the possible that diastasis or the DRA, if you're having any pelvic, low back pain or hip pain, abdominal pain, other issues have been ruled out and this continues to persist, or pain with intercourse, I would definitely recommend seeking out a referral for pelvic floor therapy. So what we see clinically is that most patients see a significant improvement in strength after 6 to 8 weeks, as long as you're consistently doing your exercises. That's how long a muscle needs to actually make physical changes. Within 3 to 4 weeks, we often see the control of urge, urinary incontinence, or urgency by doing retraining. And then we'll often see you 1 time a week or every 2 to 3 weeks, depending on you. So some people might need to be seen more, some people might need to be seen less. But like I said, with the exercises, consistency is key. Just like you're brushing your teeth in between going to the dentist, you need to do your exercises in between coming to see us. Our take-home message: listen to your body and start slow. Talk to your doctor about symptoms and treatment options. You can even call and ask for a pelvic floor referral before your 6-week follow-up. Overcome barriers to treatment. So any embarrassment that you might feel, assumption that symptoms are normal postpartum, if you're afraid you need surgery, media influence or having done KEGELs for years, or just even not knowing what to expect. We do a pretty good job at making sure you feel relaxed and comfortable. We're not going to do anything that you wouldn't feel comfortable with. Be willing to dispel the myths about incontinence. That's coming back to assuming that just because you've had a baby that you're going to leak for the rest of your life now. Understand that conservative treatments are available and effective, and then consider us as a pelvic floor therapist for your rehab. And at Renew specifically, we have 4 different locations. I'm here in Midland, and at the Bay City West location, we have 2 people at the Saginaw location and 1 in Cairo. Do we have 1 in Tawas now, Kate?
We do. We just have a new therapist that started, and she is also seeing pelvic floor patients. So yes.
Okay, and then we have 1 in Tawas.
Just this week. So.
Okay, brand new.
Yes.
All right, so thank you everyone for your time. Anyone who registered today will receive an email with my contact info, recording of the video, and exercise handouts.
Yep.
And then do we have questions?
We just had one question that came in from somebody who had a 4th-degree laceration during their delivery.
Mhm.
I don't know how long ago their delivery was, but it says that ever since then, when running or exercising, their rectal muscles just don't feel the same.
Yeah, so for sure that is not surprising, unfortunately. But like we talked about with that 4th-degree tearing, it's going into those rectal muscles. So there's a very good possibility that those muscles just have not come back on board yet with tone and strength and stability, meaning the pelvic floor muscles. So you have pelvic floor muscles that wrap around the rectal opening. So we can do assessments on figuring out what exactly is going on there and what we can do to help. Generally, we would probably do some pelvic floor strengthening and probably core strengthening for that. But we wouldn't know for sure unless we did an evaluation. But I would say if you are having any like heaviness or bulging or a lot of pressure when you're running, to probably not run as much, kind of cut it back a little bit, and then definitely see a pelvic floor therapist.
Wonderful, very helpful. That's all I have for questions. So
All
thank
right.
you for sharing with us today. And
Yes,
as always, we appreciate you.
of course.
Wonderful. Thanks, everybody.